Hematology Chapter 8 Normocytic Anemias caused by hemoglobinopathies. Hemoglobinopathies: sickle cell disease, sickle trait, hemoglobin C disease, hemoglobin C trait, hemoglobin SC disease, hemoglobin variants, hemoglobin S beta thalassemia, hemoglobin E, hemoglobin D and G, hemoglobin O. Result from one of four abnormal functions: a single AA substitution, abnormal synthesis of one of the AA chains, fusion of hemoglobin chains, extension of an AA chain. Single AA substitutions in the beta chain account for most hemoglobinopathies that manifest as hemolysis of red blood cells along with clinical symptoms. Sickle cell anemia. Valine is substituted for glutamic acid to form hemoglobin S. Homozygous. Beta chain variant. Chromosome 11. Autosomal codominant. Occurrence: African American, 1 out of every 365. Hispanic American, 1 out of every 16,300. Pathophysiology: the person inherits sickle gene, valine substitute for glutamic acid. Homozygous inheritance would mean that the majority of hemoglobin is hemoglobin S. Insoluble or rigid red blood cells in areas of low oxygen concentration such as spleen, liver, kidneys, joints, and extremities. Mishapen and inflexible red cells abstract small vessels and is here to vascular endothelium. Increasing viscosity of blood and circulation is slowed. Less oxygen. Blood pH decreases in sickle cell anemia. Escalates the cycling process. Red blood cells exit the spleen, may be able to revert to discus shape or wheat shape. Repeat sickling traps red blood cells in spleen. In physiologic conditions present may advance sickling. Hypoxia, acidosis, dehydration, fever, and cold exposure can induce sickling. Anemia. Chronic hemolytic process. Hypocellular bone marrow. Red blood cell lifespan 10 to 20 days. Marked reticulocytosis 8% to 12%. Increased bilirubin. Cholelithiasis, which is gallstone formation. Compensated anemia. Hematocrit 20 to 25%. Spleen. Initial splenomegaly. Organ drastically deteriorates by 5 to 6 years of age. Asplenia begins within 2 years. Howell jolly bodies appear and other inclusions. Repeated infractions and congestion lead to autosplenectomy, which leads to fibrosed and shriveled organ. Increased incidence of severe infection. Streptococcus pneumoniae, Haemophilus influenza, and Neisseria meningitis are causes of infection. Lungs. Susceptible to occlusion. Impaired pulmonary function. Pulmonary hypertension. Children are 100 times more susceptible to pneumonia. Acute chest syndrome. Acute chest syndrome. Fever, chest pain, hypoxia, and pulmonary infiltrates. Leading cause of death and hospitalization in patients with sickle cell disease. Vaso-occlusive episodes. Painful crisis. Tissue infarctions and sickling in small vessels produce painful target points. Caused by fever, dehydration, cold, and stress. Knowing, throbbing, and overwhelming pain. When centered in bone, it leads to tenderness, warmth, swelling, and some bone necrosis. When centered in joints, it leads to swelling, pain, and loss of mobility. Produces large pitting ulcers that are difficult to treat and slow to heal. Priapism. Persistent painful erection. Alter sexual activity and desire for activity. Erectile dysfunction. Retinopathy. Sickling lesions and stasis of small blood vessels. Retinal detachment. Possible blindness. Strokes. Infrequent. Some degree of paralysis. Coma. Seizure. Cognitive impairment. I think that's in degrees of severity, from going from infrequent to cognitive impairment. But I'm not really sure. That just looks like what it's set up as. Treatment. Keep hemoglobin F levels close to 30%. Transfusion therapy. Lab diagnosis. Normochromic normocytic anemia. Decreased hemoglobin 6 to 8. Decreased hematocrit. Decreased red cell count. Increased reticulocyte count. Slightly increased MCV. Increased bilirubin and LDH levels. Decreased haptoglobin. Extravascular hemolysis. Peripheral blood. Marked polychromasia. Nucleated red blood cells. Target cells. Sickle cells. Howell-Jolly bodies. Screening procedures. Newborn screen. Dithionite solubility test. Hemoglobin electrophoresis. Sickle trait. Heterozygous inheritance of hemoglobin S. Approximately 60% hemoglobin A. Approximately 40% hemoglobin S. Gene provides protection against malaria. Rare symptoms. Hemoglobin C disease. Substitution of lysine for glutamate. Homozygous inheritance. Milder than sickle cell. Lab findings. Normocytic normochromic anemia. Increased MCHC. Red blood cells are denser. Hemoglobin 9 to 12. Reticulocytosis. Splenomegaly. Red blood cell lifespan 38 days. Hemoglobin C crystals. 50 to 90% target cells. Pathophysiology. Hemoglobin C crystals obstruct the microvasculature and melt in the spleen. Hemoglobin C trait. 60% adult hemoglobin, 40% hemoglobin C. Lab findings. 40% target cells. Hemoglobin SC disease. 50% hemoglobin S. 50% hemoglobin C. Moderate anemia. Average hemoglobin 8 to 10. Slight reticulocytosis. Red cell lifespan 29 days. The number of target cells. Hemoglobin SC crystals. That was the end of PowerPoint for Chapter 8. Since it was kind of short, I'm going to go ahead and read from the book just to get that over with. Chapter 8 in the book is called The Normochromic Anemias Caused by Hemoglobinopathies. The key words for this chapter are analgesics, or drugs that relieve pain, autosomal, a non-sex-linked chromosome, embolism, which is an occlusion of a blood vessel, hypovolemic, which is low blood pressure, infarction, which is area of tissue that has been deprived of blood and has lost some of its function. Infiltration, the process of a substance passing into and being deposited within a cell, a tissue, or an organ. Lesion, an area of pathologically altered tissue. Necrosis, the death of cells, tissues, and organs. Placebo, substance having no medical effect when given to an individual as if a medicine. Sedation, the state of being calmed. Viscosity, in reference to fluid, the state of being thick or sticky. This chapter is meant to go over general description of hemoglobinopathies, sickle cell anemia, hemoglobin C disease and trait, and hemoglobin SC, and variant hemoglobins. I'm going to summarize most of this. The altered hemoglobin migration pattern of sickle cell individuals was due to a change in globin. This was a description of the first molecular disease. Because proteins form the basis of the globin chain, scientists began looking for abnormalities in the chain to account for what was seen in the hemoglobin electrophoresis of individuals with sickle cell anemia. The specific amino acid substitution located on the globin chain, valine substituted for glutamic acid, and the specific abnormal codon responsible for this substitution has been characterized. In molecular terms, the nucleotide triplet guanine-adenine-guanine codes for the amino acid glutamic acid in the sixth position of the normal beta chain. In sickle cell patients, adenine is replaced by thymine coding for the amino acid valine. When valine is substituted for glutamic acid, an abnormal hemoglobin S, is produced. Presently, more than 800 hemoglobin variants exist worldwide, and most are beta chain disorders. All normal adult hemoglobins consist of 2 alpha chains, which have 141 amino acids in sequence, complemented by 2 non-alpha chains, 2 beta chains, 2 gamma chains, or 2 delta chains. The non-alpha globin chains have 146 amino acids, with amino acids linked together in sequence. Hemoglobinopathies occur as a result of one of 4 abnormal functions. 1. A single amino acid substitution in one of the chains, usually the beta chain. This occurs in sickle cell trait or disease. 2. Abnormal synthesis of one of the amino acid chains. This occurs in thalassemia. 3. Fusion of hemoglobin chains. This occurs in hemoglobin lipoor. And 4. Extension of an amino acid chain, which occurs in hemoglobin constant spring. I don't know what the last 2 are. Single amino acid substitutions in the beta chain account for most of the hemoglobinopathies that manifest as hemolysis of the red blood cells, along with the clinical symptoms associated with hemolysis. Sickle cell anemia. The genetics of sickle cell anemia are not complicated, and the abnormal gene is inherited heterozygously or homozygously. Individuals who inherited 2 faulty genes develop sickle cell disease, and individuals who inherit 1 faulty gene develop sickle cell trait. Genetics and incidence of sickle cell anemia. Sickle cell anemia is a beta chain variant, and inheritance of the beta chains is located on chromosome 11. Chromosome 11 has 1 location on each chromosome for the inheritance of a normal beta chain or an abnormal beta chain. Sickle cell anemia is autosomal codominant, inherited in simple Mendelian fashion. At the moment, 100,000 Americans have sickle cell disease, 1 in 365 African American births, and 1 in 16,300 Hispanic American births. The incidence for sickle cell trait is 1 in 13 African American infants. The sickle cell gene is especially prominent in African populations near areas endemic from malaria, including Central and West Africa, some parts of the Mediterranean, Asia, Indian, and the Caribbean. The sickle cell gene is being seen with increasing frequency in non-Black populations. Symptoms in individuals with sickle cell anemia are highly variable, a direct result of the different haplotypes of hemoglobin S that are inherited. Each haplotype differs from the other by possessing different sequences of some nucleotides in the DNA strands, but they are all in the same gene cluster. Pathophysiology of sickling process. The beta chain has a carefully sequenced group of amino acids with glutamic acid in the 6th position from the terminal end. If a person inherits the sickle gene, valine is substituted for glutamic acid in the 6th position of the beta chain, and the abnormal hemoglobin S is present in the person's blood. Homozygous inheritance results in sickle cell disease, with the majority of hemoglobin being hemoglobin S. Heterozygous inheritance results in sickle cell trait, in which hemoglobin S and hemoglobin A are present. The inheritance of 1 single abnormal amino acid means that the individual inherits hemoglobin S, alpha 2 beta 2, and sets in motion myriad events that alter the individual's quality of life and lifespan. It is essential for the hemoglobin in the red blood cells to remain soluble and pliable as the red blood cell passes through the oxygenated and deoxygenated rigors of circulation. Red blood cells possessing hemoglobin S as the majority hemoglobin are insoluble or rigid in areas of low oxygen concentration, such as the spleen, liver, kidneys, joints, and extremities. Instead of having a fluid hemoglobin content, Hemoglobin S forms liquid tactoids, or polymers of hemoglobin that appear as long, thin bundles of fibers under electron microscopy. Consequently, affected red blood cells become rigid and inflexible and form an irreversibly sickled cell with a pointed projection. These mishapen and inflexible red blood cells obstruct small vessels and adhere to vascular endothelium, increasing the viscosity of the blood as circulation is slowed. Less oxygen is available to the tissues, the pH of the blood decreases, and this combination of events quickly escalates the sickling process. Sickling is also induced by hypoxia, acidosis, dehydration, fever, and exposure to cold. When red blood cells exit the spleen, they may return to the oxygenated environment of the lung, where they may be able to revert to the discoid shape or wheat shape, reversible sickle cell. For many hemoglobin S red blood cells, repeated sickling terminates their lifespan, and they are trapped in the splenic graveyard. The extent to which a red blood cell sickles depends on the amount of hemoglobin S and the amount of hemoglobin F, and the physiologic conditions present that may advance sickling. Sickle cell disease is a major health concern in areas where malaria is a high prevalence, such as Africa, the Middle East, and South Asia. However, it is believed that the presence of sickle cells prevents malarial infiltration. Clinical considerations for sickle cell anemia. Sickle cell anemia is usually diagnosed through neonatal screening processes, or between 6 months and 2 years of age. Before this time, red blood cells are protected from sickling owing to high levels of hemoglobin F. Young children present with symptoms of chronic hemolytic anemia, failure to thrive, infection, or dactylitis, which is painful swelling of hands and feet caused by sickled cells caught in the microcirculation. Basic clinical considerations for sickle cell patients fall into 5 categories as follows. Chronic hemolytic anemia, intense recurrent painful attacks, multiple bacterial infections, deterioration of tissue and organ function, shortened life expectancy. Taken together, these conditions represent a complicated set of guideposts for medical management of a patient with sickle cell disease. Anemia. Most patients with sickle cell anemia have a chronic hemolytic process that is characterized by hypercellular bone marrow, red blood cells that live only 10 to 20 days, a marked reticulocytosis, 8% to 12%, increased bilirubin, and cholelithiasis, gallstone formation. The anemia is usually compensated with hematocrit values of 20 to 25%, and patients do well even with these low numbers. However, complications occur in the form of aplastic anemia or splenic sequestration crisis. Acute aplastic anemia may develop as a result of infection, usually parvovirus, when the already overworked bone marrow simply fails to produce cells. The hematocrit may decrease by 10% to 15% per day. Transfusion is essential for bone marrow aplasia, and death may occur without transfusion intervention. Clinical considerations for sickle cell anemia individuals. Anemia. Chronic hemolysis, 20 to 25% hematocrit, reticulocytosis, transfusion dependency, antibody development. Spleen. Loss of splenic filtration ability. Functional asplenia. Splenic sequestration. The spleen bears the burden of the sickle process. Many patients have initial splenomegaly, but this organ drastically deteriorates by 5 to 6 years of age. Functional asplenia begins with the first 2 years as the spleen loses its ability to clear abnormalities from red blood cells. Howell jolly bodies and other inclusions are evident in this peripheral smear, and there is increased incidence of severe infections as the spleen cannot contribute to the immune system. Repeated infarctions and congestion of the spleen lead to autosplenectomy, producing a fibrosed and shriveled organ. This scarred organ is dysfunctional, and 2 consequences may develop: overwhelming sepsis and or splenic sequestration. Streptococcus pneumoniae infections are especially grave in this age group, but other encapsulated organisms, such as Haemophilus influenzae and Neisseria meningitis, pose serious hazards. Acute splenic sequestration refers to large volumes of blood pooled in the spleen. This is most often a complication of young children. Distension of the abdomen and hypovolemic shock occur because of the rapid pooling. Recovery is not guaranteed because the condition often goes unrecognized and treatment is delayed. Penicillin prophylaxis is essential in children younger than 5 years of age with sickle cell disease. Clinical considerations for sickle cell anemia in the lungs: pulmonary infarctions, pneumonia susceptibility in children, acute chest syndrome, leading cause of death, pulmonary hypertension. In the lungs, sickling can occur in any organ of the body, but the lungs are particularly susceptible to occlusions in the microenvironment of the pulmonary space. During the course of disease, patients may experience clinical lung conditions that are chronic or acute. Often, minute pulmonary infarctions may go undetected, but over time, these may lead to impaired pulmonary function and pulmonary hypertension, which carry a high risk of death, 20 to 40% of patients. Children with sickle cell anemia are 100 times more susceptible to pneumonia than other children. Acute chest syndrome is characterized by fever, chest pain, hypoxia, and pulmonary infiltrates. These patients are chronically ill with an average hospitalization of 10 days. Older patients tend to have a more severe course of disease. Multiple cases are suggested, including pneumonia and other infectious agents, and possibly fat embolism, although pulmonary infarction underlies each of these possibilities. Acute chest syndrome is the leading cause of death and hospitalization in patients with sickle cell disease, and should be considered in any sickle cell patient who is admitted for pain. Vaso-occlusive episodes and complications. Painful crisis is the trademark of patients with sickle cell disease. In African cultures, the descriptive words associated with this condition translate as body biting or body chewing. Tissue infarctions and sickling in small vessels produce several painful target points. Patients do not experience crisis episodes on a daily basis. For the most part, they're able to live reasonably normal lives. Yet pain is a consistent symptom in individuals with sickle cell disease. Certain events may trigger a sickling crisis, including fever, dehydration, cold, and stress. When a crisis occurs, the patient is described as gnawing, throbbing, and overwhelming, with few moments of relief. If the crisis is centered in the bones, patients experience tenderness, warmth, and swelling, and some bone necrosis. Infarctions at the joint level lead to swelling, pain, and loss of mobility. Large pitting ulcers that are slow to heal and difficult to treat may also result from joint infarction and poor circulation in the limbs. The pain of sickle cell crisis is intense and unrelenting, and analgesics provide only temporary relief. Clinicians may need to reevaluate the protocols and analgesics necessary for pain management in pediatric and adult sickle cell patients, with the goal of providing some relief and comfort. I'm going to finish off these clinical considerations for sickle cell anemia individuals with joints, painful tissue infarctions, painful swelling in joints, loss of mobility, and partial paralysis for some. Genitals, priapism, erectile dysfunction. Eye, retinopathy, possible blindness. Neurologic, stroke. Priapism, retinopathy, and stroke. Priapism, a complication of vaso-occlusion, is the persistent painful erection of the penis that usually occurs around 15 years of age, the age of puberty. This condition may persist for hours, days, or weeks, with analgesics and sedation as the main course of treatment. Repeated episodes may alter sexual activity or the desire for sexual activity and lead to erectile dysfunction. Male patients with sickle cell anemia have a high incidence of 35% of priapism, and this complication needs additional attention in the overall management of this disease. Retinopathy refers to the ophthalmologic complications that patients with sickle cell anemia experience resulting from sickling lesions and stasis of small blood vessels during the course of the disease. These complications may begin at 10 years of age and can include retinal detachment, retinal lesions, and possibly blindness. Eye examinations must be conducted regularly for patients with sickle cell anemia so that appropriate treatment can be initiated and implemented. Symptomatic strokes are an infrequent complication of sickle cell anemia, affecting only 10% of children, but they may yield serious, unpredictable setbacks to this patient group. Young patients who experience a stroke may have some degree of paralysis, coma, seizure, or cognitive impairment. Preventative measures include identifying children at risk through transcranial Doppler imaging, which may disclose the narrowing of arteries causing a blockage and hypoxia to the brain. An additional strategy is to maintain hemoglobin S levels close to 30% through transfusion therapy. This method has been shown to reduce the recurrence of strokes or prevention of first-time events from 80% to 10%. Laboratory diagnosis. Patients with sickle cell anemia have a lifelong normochromic normocytic anemia with decreased hemoglobin 6 to 8 grams per deciliter, hematocrit, and red blood cell count. The reticulocyte count is always elevated, leading to a slight increased mean corpuscular volume, or MCV, in many cases. Bilirubin and lactate dehydrogenase, or LDH, are increased, and haptoglobin is decreased, indicating extravascular hemolysis. During crisis episodes, the peripheral smear shows marked polychromasia, many nucleated red blood cells, target cells, and the presence of irreversible and reversible sickle cells. Peripheral smears from sickle cell patients not in crisis show minimal changes, a few oat-shaped reversible sickle cells and some polychromasia. A white blood cell count may need to be corrected for nucleated red blood cells by applying the following correction formula if automated instrumentation lacks this correction formulation. Correct white count equals original white count over 100 plus nucleated red blood cells, all times 100. First level screening procedures for adults include dithionate solubility, a solubility test based on the principle that hemoglobin S precipitates in high molarity buffered phosphate solutions. The amount of hemoglobin S is insignificant in this screening procedure because the purpose of this procedure is to detect the presence of hemoglobin S in the test sample. The endpoint is easy to read as a turbid solution in the presence of hemoglobin S and a clear solution if hemoglobin S is not present. Newborn screening for hemoglobinopathies occurs in most states and for all ethnic groups in the United States and provides the opportunity for early diagnosis and intervention for patients with sickle cell anemia. Key ingredients for successful disease management. Most newborn blood samples are obtained by heel puncture, and the blood is collected onto filter paper and allowed to dry. The samples are analyzed by hemoglobin electrophoresis at alkaline and/or acid pH, isoelectric focusing, or high-performance liquid chromatography, a reference procedure not discussed here. If electrophoretic techniques are used, two bands at hemoglobin F and hemoglobin S are seen in patients with sickle cell anemia because hemoglobin F is predominant in neonates. A healthy neonate shows two bands at HbA and HbF, whereas a neonate with sickle cell trait shows three bands, one at hemoglobin F, one at hemoglobin A, and one at hemoglobin S. At 1 day old, hemoglobin F percentage should be around 77%, and hemoglobin A should be around 23%. Up to 12 months, hemoglobin F presence should be 1.6%, and hemoglobin A should be around 98.4%. At adulthood, hemoglobin F should be at less than 2%, and hemoglobin A should be at 98%. Challenges in neonatal screening involve identifying unexpected bands and small amounts of hemoglobin A or S. Hemoglobin electrophoresis. This is a time-honored quantitative procedure for isolating hemoglobin bands. This technique is based on the principle that hemoglobins migrate at different positions depending on pH, time of migration, and media used. Cellulose acetate and citrate agar are the media most often selected. Hemoglobin is isolated from a patient sample using various lysing agents such as saponin or water. A small amount of sample is applied to the media and electrophoresed for the prescribed amount of time, and then each band is quantified using densitometry. In analyzing each group of patterns, several features must be kept in mind to identify the abnormal hemoglobin properly. On cellulose acetate in an alkaline electrophoresis, hemoglobin E, C, and O Arab and hemoglobin A2 migrate to the same position, and hemoglobin S, hemoglobin D Punjab, and hemoglobin G phyla travel together. On citrate agar in an acid pH, hemoglobin A, O, A2, D Punjab, G phyla, and E migrate to the same point. This medium provides excellent separation, however, for hemoglobin S from hemoglobin D Punjab and C from E. In practice, most laboratories use a screening technique followed by a known quantitative method that has been carefully developed for their hospital setting. Equipment cost, technologist time, and the number of samples to be evaluated factor into the decision as to whether the quantitative technique is performed on-site or sent out to a reference lab. Isoelectric focusing, or IEF, is the method of choice for most newborn screening in the United States. This refined electrophoretic procedure uses a pH range of 3 to 10 in polyacrylamide gel. Within this pH range, hemoglobins achieve their isoelectric point, their point of no net negative charge, and they focus into sharp, distinct bands. Because each hemoglobin is a protein with a distinct amino acid composition, clearly defined points are achieved. This procedure is especially useful when small amounts of abnormal hemoglobin need to be detected. The cost of equipment for IEF is prohibitive in most community hospital settings, but this technique has great value for large batch analysis such as newborn screening performed in state health laboratories. Sickle cell trait. Individuals acquire the sickle cell trait through heterozygous inheritance of hemoglobin S, which results in the possession of hemoglobin A at approximately 60% and hemoglobin S at approximately 40%. These individuals are hematologically normal. Approximately 2.5 million people in the U.S. carry the sickle gene. The prevalence of sickle cell trait is 8 to 10% among African Americans. Population penetrance in parts of Western Africa is 25 to 30%, and the protection the gene provides against malaria is considered to be a large factor for the frequency of this gene in parts of Africa. Several circumstances may put an individual with sickle cell trait in jeopardy of having a crisis episode, such as air travel in an unpressurized cabin and high altitudes. Other than this, sickle trait individuals lead normal lives. In a perfect world, all African Americans would know their hemoglobin S status because a union with another individual carrying sickle cell trait could produce a child affected with sickle cell anemia, which is a 1 in 4 chance. It is important that individuals understand the potential risk of the sickle cell's gene so that informed decisions can be made. Hemoglobin C disease and trait and hemoglobin SC. Hemoglobin C is a substitution of lysine for glutamic acid, alpha 2 beta 2, in the 6th position of the N-terminal end of the beta chain. If hemoglobin C is inherited homozygously, the individual has hemoglobin C disease. If hemoglobin C is inherited heterozygously, the individual has hemoglobin C trait. Hemoglobin C disease has milder clinical symptoms than sickle cell anemia and has much lower prevalence among African Americans, 2 to 3%. In northern Ghana, the incidence of this particular hemoglobin is 17 to 28%. The anemia is normochromic and normocytic, yet there is some increase in the mean corpuscular hemoglobin content, MCHC, because red blood cells from homozygous individuals are denser. Most homozygous individuals show a moderate anemia with a hemoglobin value of 9 to 12 grams per deciliter. There is a moderate reticulocytosis and splenomegaly. The red blood cell lifespan is 38 days, yet few patients exhibit any symptoms. Of particular interest is the possible presence of crystalline structures in the red blood cells that appear as blocks or bars of gold. These peculiar crystals obstruct the microvasculature but melt in the splenic microenvironment. Consequently, splenic function is preserved and little pitting occurs. Target cells, 50 to 90%, are the predominant red blood cell morphology, and variations of targeting may include folded or pocketbook-shaped cells. Spherocytes may be present. Alkaline electrophoresis shows a single slow-moving band in the same position as hemoglobin A2. The heterozygous condition is termed hemoglobin A-C trait, with a ratio of 60% hemoglobin A and 40% hemoglobin C on alkaline electrophoresis. There are no clinical complications for individuals with this condition, and they may never be noticed except for the presence of 40% target cells on their peripheral smear, an extremely abnormal finding. Individuals who inherit hemoglobin C should be aware of their hemoglobin status and the hemoglobin status of prospective mates. Hemoglobin SC disease is a combination of two abnormal hemoglobins, hemoglobin S and hemoglobin C. Affected individuals have a moderate anemia with an average hemoglobin of 8 to 10 grams per deciliter, with a slight reticulocytosis. Red blood cell lifespan is reduced to approximately 29 days. Although the disease is less severe than sickle cell anemia, an individual may experience a painful crisis. Pregnant women may be severely affected. The peripheral smear shows high numbers of target cells, few reversible sickle cells, and folded cells, with a peculiar crystal shape like the Washington Monument or a gloved hand showing some cells. The hemoglobin distribution on alkaline electrophoresis is 50% hemoglobin S and 50% hemoglobin C. Variant hemoglobins. Some individuals have two abnormal hemoglobins, e.g., hemoglobin S beta thalassemia. In this case, the individual would have clinical conditions related to both of the genetic abnormalities. Additionally, this section features other abnormal hemoglobins that have been noted in the general population. Hemoglobin S beta thalassemia. The hemoglobin S beta thalassemia combination hemoglobin may produce a clinical picture as severe as sickle cell anemia, with virtually no hemoglobin A present. The anemia is microcytic, hypochromic, showing the influence of thalassemia gene, with nucleated red blood cells, target cells, polychromasia, and sickle cells. The red blood cell distribution width, RDW, and the reticulocyte count are increased. As opposed to the usual presentation of sickle cell anemia, splenomegaly is usually present. The overall severity of the condition depends on the beta thalassemia genotype inherited. Patients inheriting B have a more severe presentation. On alkaline electrophoresis, two bands are present, one at the location of hemoglobin S and one at the location of hemoglobin A. Hemoglobin E. Hemoglobin E has an extremely high prevalence in individuals from Southeast Asia. Individuals may inherit the hemoglobin either heterozygously or homozygously. The homozygous conditions of this abnormal hemoglobin present no clinical complications. Individuals show a marked microcytic hyperchromic picture with some target cells and slight polychromasia, but are asymptomatic. On alkaline electrophoresis, there is a strong band located in the same position as hemoglobin C or hemoglobin A2. The heterozygous condition shows 70% hemoglobin A and 30% hemoglobin E. Hemoglobin E is the second most common hemoglobin variant worldwide and is being seen with increasing frequency in the United States because of the large numbers of Southeast Asians emigrating to North America. Hemoglobin D Punjab and hemoglobin G phyla. Hemoglobin D Punjab is a rare clinical variant in which both genetic states, homozygous and heterozygous, are asymptomatic. There is a higher incidence of hemoglobin D Punjab in Great Britain, and this is thought to reflect the large number of Indian wives brought to England during Great Britain's long occupation of the Punjab region of India and Pakistan. The prevalence of this variant in these regions is 3%. Although rare, Hemoglobin G phyla is seen in African Americans with a high incidence in Ghana. It is an alpha chain variant that migrates in the same position as hemoglobin S as alkaline electrophoresis at pH 8.6. There are no hematologic abnormalities. Hemoglobin O Arab. Hemoglobin O Arab is an uncommon hemoglobin found in 0.4% of African Americans. Most individuals are asymptomatic, but this hemoglobin must be distinguished from hemoglobin C at alkaline electrophoresis because it migrates to the same location. Citrate electrophoresis at pH 6.4 isolates this band for positive ID. There's a condensed case here about a 6-year-old Indian girl who was brought to the emergency department with fever, malaise, and joint pain. Lab results were 13,000 times 10 to the 9th liters per liter white blood cells, hemoglobin at 9 grams per deciliter, hematocrit at 27%, and MCV at 85. Her peripheral smear revealed a moderate number of target cells with 2+ polychromasia and moderate oat-shaped cells. Based on her peripheral smear and the fact that she is anemic with joint pain, sickle cell anemia is a strong possibility. This condition needs to be confirmed with hemoglobin electrophoresis or IEF. Oat-shaped cells are reversible sickle cells seen in many patients with sickle cell anemia. Her bone marrow is responding because she is exhibiting polychromasia. Splenic function needs to be monitored carefully in pediatric patients. The summary points for this chapter: most hemoglobinopathies are the result of single amino acid substitution in the beta chain. In sickle cell disorders, valine is substituted for glutamic acid in the 6th position of the beta chain. In hemoglobin C disorders, lysine is substituted for glutamic acid in the 6th position of the beta chain. The presence of hemoglobin S affords some protection against malarial infection of red blood cells. Cells containing hemoglobin S, as the majority hemoglobin, are insoluble in areas of the body with low oxygen tension. Sickle cells clog small vessels during sickling crisis, causing extensive organ damage and pain. Homozygous inheritance of hemoglobin S produces sickle cell anemia, or hemoglobin SS. Heterozygous inheritance produces sickle cell trait, or hemoglobin AS. Hypoxia, acidosis, dehydration, cold, and fever predispose a patient to sickling episodes. The only Food and Drug Administration approved drug for adults with sickle cell disease is hydroxyurea. Autosplenectomy is a consequence of repeated infarctions to the spleen in young children with sickle cell disease. Stroke and acute chest syndrome are serious complications in patients with sickle cell disease. During sickle crisis episodes, patients show nucleated red blood cells, sickle cells, target cells, and polychromasia. White blood cells may need to be corrected owing to the presence of nucleated red blood cells during sickling episodes. Individuals with sickle cell trait are asymptomatic with rare abnormalities in the peripheral smear. Newborn screening for hemoglobinopathies is available in the United States through state health laboratories. Dithionate solubility is the usual screening procedure to determine if hemoglobin S is present. Acid or alkaline electrophoresis and IEF provide better methods to isolate hemoglobin bands. Hemoglobin C disease occurs when hemoglobin C is inherited homozygously. Hemoglobin C trait occurs when hemoglobin C is inherited heterozygously. Hemoglobin C disease may produce hemoglobin C crystals on Wright's stain. Hemoglobin SC is the result of inheriting 2 abnormal hemoglobins, hemoglobin S and hemoglobin C. Hemoglobin SC may produce abnormal crystal formation resembling the Washington Monument or fingers in a glove. Hemoglobin S beta thalassemia may produce conditions as severe as sickle cell disease. Hemoglobin E is the second most prevalent hemoglobin variant and is seen with great frequency in Southeast Asia. Hemoglobin D Punjab and hemoglobin G phyla migrate with hemoglobin S on alkaline electrophoresis. In the case study, a 3-year-old boy of Ghanaian ethnicity presented to the emergency department acutely ill with fever, chest pain, and heavy cough. He was brought by his parents, who said that he seemed to have a mild cold and slight fever. His condition, however, had become more serious in the last 24 hours. His temperature was 103 degrees Fahrenheit. His parents informed the emergency department staff that he has diagnosis of sickle cell anemia, but they thought this episode was different from his previous crisis episodes. A CBC was ordered, and he was helped to cough up a sputum sample for culture. He was given ibuprofen for pain and fever. He was admitted 4 hours from the time he was seen in the emergency department and put in the critical care unit in grave condition. His breathing was compromised, and he was placed on mechanical ventilation and lapsed into a coma. He developed disseminated intravascular coagulation, or DIC, and required 10 units of fresh frozen plasma, 10 units of platelets, and 20 units of packed red blood cells to control the bleeding. He died as a result of overwhelming sepsis 24 hours after admission. Initial results are listed. White blood cell 20 times 10 to the 9th, red blood cell 3.5 times 10 to the 12th, hemoglobin 11.5, hematocrit 34%, MCV 97 fluid ounces, MCH 32.9 pg, MCHC 33.8%, platelets 160 times 10 to the 9th, RDW 18%. The differential showed a left shift with heavy toxic granulation and Dolly bodies. The initial coagulation results are as follows. PT 12 seconds, with the normal values being 11 to 13 seconds. PTT 26 seconds, with the normal value being less than 40 seconds. This account represents the worst case scenario for a young sickle cell patient. Patients in this age range who have sickle cell anemia are vulnerable to virulent infections by encapsulated organisms, acute chest syndrome, and dactylitis. When they are admitted to the hospital, coordinated care by a staff knowledgeable about sickle cell complications is crucial because time is usually the enemy, and the situation can rapidly escalate. In this case, even though the parent mentioned the child's sickle cell diagnosis, he was treated far too casually and not as a young child with special medical needs. Streptococcus pneumoniae grew from his sputum culture, and a gram-positive organism was seen on gram stain, but he was not treated aggressively when one considers that his spleen was compromised. Functional asplenia is serious and life-threatening, especially if the patient becomes infected with an encapsulated organism. Patients such as this merit special attention. This patient died as a result of overwhelming sepsis because of the streptococcal infection, which triggered DIC and uncontrollable bleeding. His platelet count plummeted to 40,000 within 2 hours of admission, and he began to bleed from the venipuncture site. He was too young to withstand the numerous assaults on his body system. Chapter 8 Review Questions. 1. The amino acid substitution in patients with sickle cell anemia is valine for glutamic acid. 2. Dehydration contributes to the pathophysiology of sickling. 3. Most of the clinically significant hemoglobin variants are single amino acid substitutions. 4. Hemoglobin E ranks second in variant hemoglobins worldwide. 5. Hemoglobin CC disease shows crystals appearing like bars of gold in the peripheral smear. 6. Acute chest syndrome is the leading cause of hospitalization for sickle cell patients. 7. Isoelectric focusing is the hemoglobin separation method that is used for most newborn hemoglobin screenings. 8. Hemoglobin A2, hemoglobin C, and hemoglobin E migrate to the same location at pH 8.6. 9. When nucleated red blood cells are present, a correction is necessary on total white blood cells because nucleated red blood cells are counted as leukocytes. 10. Target cells, nucleated red blood cells, and polychromasia may be seen in the peripheral smear when a sickle crisis has occurred. Not moderate elliptocytes, though.